In the trenches, today we're going to be talking about shock. That was today's request. Shock is a condition where you're not getting enough oxygen to tissues. Okay, you don't get enough oxygen to tissues and to organs, they die and the patient dies. When you're approaching shock, you want to figure out the cause of shock. Okay, so you could have vasodilatory shock, most likely septic shock, sometimes anaphylaxis. You could have cardiogenic shock, either an acute MI, a mechanical complication of an MI, progressive heart failure, arrhythmia-induced cardiogenic shock, but the primary problem is with the heart here. Okay, hypovolemic shock, most likely bleeding and bleeding from the GI tract. Sometimes you could have an adrenal crisis, which could precipitate something like this under the right circumstances. And then the fourth category is obstructive shock, which is something blocking blood flow. A massive PE where you can't get blood from the right side of the heart to the left side of the heart. Cardiac tamponade, you can't fill the heart, no blood goes in, nothing goes out. Attention pneumothorax. So the way you could approach this thinking is pumps, pipes, perfusion, and pharma, the 4 Ps. Okay, here this is cardiac, septic, volume depletion, bleeding, and medications. Okay, another way you could look at the physiology: cardiogenic shock, low cardiac output, high SVR, high wedge pressure. Septic shock, high cardiac output, low SVR, low wedge pressure. Hypovolemic shock, bleeding, low wedge pressure, low cardiac output, high SVR. So how do you approach this? If you have septic shock, okay, if you have septic shock, you have to look for the source and you have to give fluids. Okay, you can give fluids right away. Now it's a debate whether you really pour on the fluids or you give aggressive fluids, but you add pressors and not as much fluid. And whether you can have a balanced solution like the lactated ringers versus normal saline. More of the data is hanging with a balanced solution like lactated ringers. The different studies, some show differences, some show no differences. Then you're going to look for the source. Is it the urine? Is it the hepatobiliary system? Is it skin, cellulitis, necrotizing fasciitis? Is it the lungs? An exam has to be quick, but still an exam looking for the source. And if you feel it's sepsis, then you're going to have to give antibiotics right away. If you're not sure where the source is, broad spectrum, covering gram-positive, especially staph, including MRSA, gram-negatives, in certain situations, anaerobes, and MRSA. And you're going to image the patient, look for the source, either the kidney, the lung, the hepatobiliary system. If the liver biochemistries are abnormal, you're going to look for a blockage in the common bile duct. If there's flank pain and suggestion of kidney stones, you're either going to do a CAT scan or an ultrasound of the kidney. Concerned about pneumonia, obviously you're going to be doing a chest x-ray, and then you're going to get antibiotics in right away. Cardiogenic shock, it depends. You go with the history. Someone's having crushing chest pain, ST segment elevations in their anterior precordium. You're going to look for an anterior wall MI that's causing this. They're going to go right to the cath lab for an intervention. They have a history of chronic heart failure. It might be progression of a chronic disease. These patients may need mechanical intervention like a balloon pump or ECMO, or an impelling catheter if the right ventricle is involved. But they're could need to be assessed and treated very rapidly. often they wind up in the cath lab. If it's hypovolemic blood loss, usually the GI tract, you're going to have to determine if it's upper versus lower. You're going to give them fluid, you're going to give them blood, and they're going to need, probably if it's lower, they're going to need some type of CT angiography, see if there's a bleeding blood vessel area, and then go in and attempt to intervene and embolize it. If it's an upper GI bleed, then GI's going to need to do endoscopy, and possibly if they're varices, they need to treat the varices. If it's a bleeding ulcer or another lesion, AVM, they might need it cauterized. And if it's a PE, now PEs are treated with stent thrombectomy, with flow retriever rather. They used to give thrombolytic therapy. It might be dealer's choice depending on what institution you're at. If it's tamponade, you have to treat the tamponade, which would involve pericardiocentesis or possibly a window. Tension pneumothorax would require chest tube drainage. Often in the EDs now they do rapid ultrasound for shock and hypotension, and they can see a lot of these things, and this could clue you in. And this could clue you in. As the etiology, if you see a big hypovolemic, big dilated left ventricle, it's cardiogenic shock. If the ventricle is hyperdynamic, you think a septic shock. If dilated RV and normal LV and the IVC's not collapsing, you could think of a massive pulmonary embolism. That's a helpful tool. The other thing is depressors in the treatment. Obviously, these patients are going to go to the ICU. Often the first vasopressor given in such a shock is norepinephrine or Levophed. And if that doesn't do what you need to do, often the second vasopressor is vasopressin. Sometimes dopamine's used. And sometimes, even if they're not adrenally insufficient, stress dose steroids are used. Hydrocortisone 50 milligrams, Q6 hours. That's debatable in the literature. There's some positive, some negative studies. If they're in cardiogenic shock, they might need vasopressin. This way to give them blood pressure. Often they're placed on inotropic agents like milrinone until the situation's straightened out, or using a combination. Hypovolemic shock, you give them fluids. If for whatever reason you suspect adrenal insufficiency, you give them stress dose steroids. And you're going to give them blood, and you're going to intervene if it's a pulmonary embolism, either flow retriever or thrombolytic therapy. And that's a quick talk on shock.